I have no disclosures. Just a few things about chest trauma. So trauma is the leading cause of death worldwide. 2/3 of the patients have chest trauma, and blunt chest trauma being more common. Now, in terms of death, what we see is that a large number of these deaths are actually due to the chest trauma, but because most of them actually die at the scene of the accident, they don't make it to the emergency department. And what we see are the more commonly are the visceral injuries and the other kind of injuries. Just a very few things about the technical aspects of TEVAR. Each device has its own brochure, which gives you the indications for use. What we need for planning purposes are 1 mm cuts so that we can reconstruct them in the sagittal and coronal plane. Aside from that, the other thing to be aware of that we need at least a 15 mm landing zone. And what that means is the top part of the graft has to be beyond 1.5 centimeters of where the aneurysm starts. Now, this is a particular problem because a lot of these ruptures, dissections, or pseudoaneurysms commence just beyond the left subclavian. So to achieve that 1.5 centimeters, you will have to cover the left subclavian. Now, covering the left subclavian in itself isn't a major issue, except that we have the left vertebral coming from the subclavian. So that's why we need to image the circle of Willis and make sure that the circle is complete, because even if you do a carotid subclavian bypass later on, they're still going to have a massive vertebro-basilar stroke. In terms of how successful they are, initially, the older studies, as Dr. Jamshed mentioned, which were performed maybe 20 to 30 years ago, they showed a very high incidence of endoleaks, up to 40%, but those numbers are considerably better nowadays. So what are the indications for TEVAR? Number 1, aortic aneurysm. What size? Well, difficult to be sure. Some people say 5.5, some say 6. It depends basically, is it fusiform or is it saccular? Is it a male or a female? Females have, people have said that, especially if they're premenopausal, their sacs can increase in size at a greater rate. The other thing is that I'm not talking about mycotic aneurysms or dissecting aneurysms. I'm talking about just the straightforward normal aneurysm. So the other thing to consider is the rate of growth. And finally, there was a nice Irish study, and they said, look, you need to look at how tall the person is as well. Average Japanese is not the same as the average American. And so we have to keep those things when we look at these guidelines. Traumatic aortic transection. So just as I mentioned, these transections typically happen just beyond the origin of the left subclavian. And there are 4 kinds, grade 1, 2, 3, and 4. And there's a nice picture here that I want you to look at. And what you need to appreciate is that the grade 1 is an intimal tear, which previously used to be managed conservatively, although evidence suggests that these need to be TEVAR'd as well. And certainly the grade 2, which is an intramural hematoma, grade 3 is a pseudoaneurysm, and grade 4 is a rupture. Now, I've gone through many of our CT reports at Shifa, and I think the reports are quite good. They give a very good descriptive information about what's happening within the aortic arch. And then the same description is put at the end, and often it's quite a lengthy report. In this particular patient, we can see that there's a grade 1. I've put stroke 2 transection because I think there is a little bit of an intramural hematoma. But certainly he has an intimal injury. As we can see, we've got clot over there. And you can, as you follow it down, you can see it, and you can see it here in the coronal section. And we used the Cook Zenith alpha graft, and we've got a good result. We've actually published several of these in one of our local journals. This is a case of a 27-year-old, again, road traffic accident. Again, he's got a traumatic transection. What I wanted to highlight in the second part of the slide is that when we CT these patients, we do the head, neck, chest, abdomen, and pelvis. And these patients often have significant injuries of their limbs, which are not seen on the CT, and they're sort of picked up by the orthopedic people. So these are actually quite complex patients who have lots of long bone fractures. So coming back to this, rather than putting a very detailed report in the middle of the night, if I was on call, this is how I would report the scan. This is my full detailed report. Grade 3 aortic transection, urgent vascular consult is mandatory, and that's Dr. Umar, and I can give you his mobile. He's not listening, so I'm sure he's fine with that. Other injuries noted. Basically, I don't care what's happening in the rest of the limbs and the body and everything else. I want this grade 3 aortic transection done tonight. And the rest of the scan can be looked at later, and I can attend this discrepancy meeting later for all the fractures I've missed. So here we have another case. I think you saw this one earlier, and you can see we've got a pseudoaneurysm. This particular case was very interesting, and I want you to look at the timeline. So the patient comes into Shifa and he has his CT performed on the 15th at 7:13. There are possibly some delays in the radiology department, and finally an IR consult is made at 10 a.m. the next morning. Now once we've been consulted, we've engaged the company engaged their various managers, and they go through the different hierarchy. But almost within 12 hours at 2:30 a.m. the next day, the graft has left Dubai, and it arrives in Islamabad at 7 a.m. And the procedure is completed the same day at 16:58. That is the time the last image was acquired. So it takes a few hours to do this case. We have to get anesthesia on board. We have to get the IR. So the patient probably went in around lunchtime. So this just shows you how fast we can get things done. Now, the Medtronic people currently have actually given us some stent grafts, and while they may not be in Islamabad, they may be in Lahore, but we can certainly get hold of them much easier than we could in the past. But like I said, you know, even just flying it in from Dubai, it doesn't take ages. This is just showing you the same case, and here you can see the stent graft there, the stent graft's been pulled back. The bare metal portion projects above the subclavian, and we've partially covered the subclavian over here, which is fine. So we've got an adequate seal zone, and we've kept perfusion in the subclavian. And then this is the Coda balloon catheter just to seal that top end. And this is the images obtained afterwards. And everything looks very good. This is the initial, and that's the follow-up CT. So 42 years old female, another road traffic accident. She's got some cerebral injuries, and she's got lots of other fractures, but I'm not interested in any of that. Okay, I am interested in the cerebral side of things because brain does come first, but after brain, it's the aorta that we're concerned about. And what I want to see in the report is grade 4 aortic transection, vascular consult, and then angiosuite. And this patient, you can see that apart from where you can see you've got the tear in the aorta, look at the amount of surgical emphysema. Patient's got chest drains in. She's not in a good condition, but she successfully had a endograft done. And this was the slightly older Zenith TX2, which has now been replaced by the Zenith Alpha. I didn't have any dedicated angiographic follow-up, but I do know that she is alive, and I can see the orthopedic people have done some follow-up, and there was a non-contrast CT showing the bottom of the stent. So she did well. So continuing with the indications for TEVAR, management of type B dissections. So we're concerned with, when you have a dissection, is the malperfusion. The coverage of the entry tear with the stent graft allows re-expansion of the true lumen and improved organ perfusion. We're also concerned about the size in terms of rupture. Traditionally, we used to say that if it's a type 1 tear, you can just manage them conservatively, give them some medications, and they'll be fine. That's following the INSTEAD trial. However, the INSTEAD trial was repeated 5 years later, and this is the important thing. And they've said that even for those grade 1 tears, which we used to manage conservatively, in the long run, you're better off doing a TEVAR. So basically, any aortic injury equals TEVAR. Admittedly, type 2, 3, 4 probably need to be done straight away. Type 1 can be done the following day. Here you've got a, just to give you, there are different multiple guidelines, but just here where they're talking about measuring the total lumen and then the flow lumen of the thoracic aorta. And just saying that basically if the diameters exceed this, then, you know, these benefit from early stent grafting. So this is another lady, excruciating chest pain radiating to the back, rule out pancreatitis or cholecystitis. And what we can see is that's the cause of her back pain. So she's got a type B aortic dissection with thrombosis of the false lumen. And it's quite an extensive dissection. You can see as we follow it down. If you just look below the renal artery on both sides, the images are not in the same plane, but you can see the renal artery coming in. And that's where you can see the false lumen, which is not thrombosed. So again, she had a successful TEVAR, and you can see the graft. So that the top part of the graft, which is called the crown, that doesn't have any fabric around it. So the fabric starts where the stent markers are. And you can see that we're partially encroaching on the left subclavian. So we're keeping the subclavian perfused while getting a good seal. 33-year-old, history of a road traffic accident. Again, he's got lots of other injuries. And here you can see another grade 3 aortic transection. And you can just see that in the axial images. And what you see here at in the angiographic phase is you can see a filling defect on the inner border of the aorta. And again, this one was also successfully managed. I'm not going to go into too much details. Just mention penetrating aortic ulcer and intramural hematoma. These penetrating aortic ulcers, we do see them from time to time, and you need to be very careful, because if the depth is more than 10 or the width more than 20, then probably they need to go for TEVAR. I'm not going to go through too much detail in this slide. Thoracoabdominal aneurysms. Yes, that's one of the indications. So we talk about snorkels and chimneys and periscopes, and what are all these different things? So basically, this is where we're having to cover an important visceral branch. And when we do that, we need to keep it perfused. So Dr. Jamshed already mentioned those dedicated tailor-made stent grafts, but this is the cheaper alternative. And what you do is that you can cannulate the renals or the subclavian or any other vessel, and depending on which fashion you recanalize it. This is a snorkel. It's called a snorkel, just similar to what the people who do the swimming underwater wear. And then this is the sort of more traditional FEVAR with the dedicated fenestrations. So clinical outcome, TEVAR, very good and getting better all the time. Mycotic aneurysms. So we've got an infection from somewhere, it hit the endothelium, the aortic wall has become diseased and it's now become aneurysmal. It's a big problem, what to do? Here we've got one such patient and she's got a large pseudoaneurysm in the descending thoracic aorta. Look at the lungs, look at the bronchiectasis. And she actually had symptoms for almost a year before this was picked up. So this had been slowly growing. And again, we put in a nice stent graft and sorted her problem out. She had a small endoleak. We used a catheter molding balloon and no leak was seen at the end of the procedure. We had a good proximal, good distal seal. Again, another 71 years old male, another very large aneurysm, mycotic. I just want you to note that there are 4 vessels coming off the aortic arch. So you've got the left vertebral, which is the smaller one in between. So we have to be careful that we don't cover that. And there you can see the aneurysm. And there you can see that the left vertebral remains. And these are the pictures. And that's the follow-up comparison. So they did very well. Right, so endovascular management of coarctation of the aorta. So this is a childhood problem. Having said that, 20% of patients do not present until adulthood. So what do we do with these? Here's a paper we well, a poster that we published recently. And these are a couple of cases. So this was a 44-year-old gentleman, uncontrolled hypertension. Look at the huge number of collaterals, and you can see how small the descending thoracic aorta is. And you can also see a large number of collateral vessels over there. And you can see another large bridging collateral over here. And what we used here was a Bentley stent graft, and you can see the pressure as we're inflating that graft. So this is a high pressure balloon inflated short stent graft. What can happen is when you're doing this is that you can rupture the aorta. If you rupture the aorta focally, not a problem. We've got a stent graft in position. Our stent graft is not very long. So if we dissect it and have a significant rupture, the patient will be dead within a few minutes. Fortunately, we have a TEVAR standard Medtronic stent graft in the angio suite lying right there to be opened and deployed within a matter of 2 to 3 minutes. Stiff wire is there. We've got surgical cut down. We just have to open it and deploy it. We've not had to do that, and this patient did very well. Another patient, much younger this time, he flew in from Dubai because the insurance company thought it was cheaper to get it done in Pakistan. They wanted to put a TEVAR in Dubai. I don't think the TEVAR has sufficient radial force to actually expand a coarctation. I think the TEVAR would have failed in his case. This patient, because he had an outside imaging, I did some dedicated angiographic imaging, and I actually measured his pre and post coarctation pressures, and we can see that there's a huge difference. And you can see all those collaterals coming off. So again, we've got access via the left subclavian. We've also got access via the groin. And you can see that it's a very, you've got a stenosed segment. You've then got post-stenotic dilatation. And here you can see the stent graft going up. Again, as a backup, we have a standard TEVAR lying right next to us, should we need it. He does very well. Notice that we don't fully inflate the balloon. I like to keep an hourglass appearance, and that's to stop stent migration. So by keeping that stent graft in that position, that is not going to migrate. And that is the reason behind not fully deploying it. And this is the largest size short stent graft available. And you can see here the final images over there. And again, he's also done very well. Another very interesting case, which to my knowledge is the only one published on the planet. I say that because he has a coarctation, which is one problem. He has a mycotic thoracic aneurysm, which is the second problem. And thirdly, to cover this, we're going to have to cover the left vertebral, which I said is something we don't do. And this patient actually has an incomplete circle of Willis. So if we cover it, she will definitely stroke. This is a case I did some years ago, and while it's been published, I don't have the original images. But just to say that she's had lots of issues. She was septicemic, unfit. Although she's very young, she was very unfit. And in the recons, you can see that they one labeled with number 1. So that's the left subclavian, and it's also a dominant left subclavian. So there is no way you can get away with covering a dominant left subclavian. So what we did is we did what we call a chimney. A chimney is where you put in a stent graft in the left vertebral at the same time via the right brachial, and at the same time you put in the aortic stent graft, and then you inflate both of them at the same time. And that way you have preserved flow both in the left vertebral and within the aortic arch. We did cover the subclavian because it wasn't an issue. She did very well. I wish I had better pictures, but this is just sort of showing you what we're doing. So in the first image, you can see that as the flows comes out of into the ascending aorta, we're gonna keep that other vessel perfused. Now, when we're planning these stent grafts, it needs a little more technical detail, because by putting in another stent graft there, you're almost creating a type 1 endoleak, which is considered an absolute sort of contraindication. So therefore, you have to get the sizing right. So we have to oversize these grafts to allow for infolding of the main body when we put these chimneys in. But lots of people are doing them. And when you put a chimney in the renal artery, they call it a periscope. If it's pointing downward, it's called a periscope, and a snorkel if it's pointed upward, and if it's in the aortic arch, it's called a chimney. And this is something that's not, well, it is a little bit challenging, I'll say, from the standard EVAR. And this is just the same patient, and just saying that she did very well. Sepsis resolved. And don't forget, this was mycotic, this was infected. So we have a certain protocol for how we deal with these infected aneurysms when we're putting in foreign body-like stent grafts, but I won't go into that detail. This is my last case. So these dissecting aortic aneurysms, this is a patient we scanned at Shifa, and I noticed that she had this aneurysm, and then she had a follow-up aneurysm. Now, initially, the aneurysm was sort of in the descending thoracic aorta, starting at sort of the T5 level, but later, as time progressed, it not only did the aortic sac expand, the dissection also extended more antegradely. So now we've got something that was potentially treatable into something that is now not potentially treatable, because now she needs major cardiovascular surgery and interventional radiological support. And you can again see the increase in size of the sac, again pinching off the celiac trunk. You can see here how it appears that there are 3 lumens over there, but it's actually the way the true lumen is now sort of divided and going into the common iliacs. And here you can just see the whole thing wrapping around. And if you look at the left subclavian, you can see the false lumen has now gone into the left subclavian. So now if you need a seal, how are we going to get a 15 millimeter seal? You'll be going into the left common carotid territory. So here now you're going to have to fall back to surgical options. But I think she's got lots of other issues. Otherwise, even now you could consider some sort of chimney technique, but I think she had lots of issues, and that's why it wasn't done in the first instance. So thank you all very much for attention.